Hello, everyone. It's a pleasure to be the opening symposium for this ECHO in Vienna, so welcome. And thank you, Tim, for actually setting so wonderfully the scene and discussing the use of steroids, drugs that we think we know so well, to treat patients with inflammatory bowel diseases. And indeed, it is my role to talk to you a little bit about the hidden figures, so what you may not know about what is going on outside of your care, but actually also in your own clinic, what is going on with our patients. So we all know that corticosteroids are very important therapies for patients with ulcerative colitis and Crohn's disease. It's undoubted. However, we're also aware of their significant side effects for our patients. This was shown for patients with adult IBD as well as for pediatric patients. And because of that, about 10 years ago already, the American Gastroenterology Association already established quality indicators, and you see in front of you what they mean, to a measurement set aimed at increasing patient safety, improving treatment, decreasing steroid use, and decreasing complications related to treatment. And actually, in the last few years, they actually set that as quality indicators measured. And you see in front of you the many quality indicator measures, but you see that two of them, actually, not one, are addressing steroid use. Recommend prescribing steroid-sparing therapy, you're asked to do if you want to keep quality in your clinics, and address steroid-related iatrogenic injury and assess bone health if steroid exposed. So both addressing steroid use in patients with IBD. And the consequences, we think we know, but look at the myriad of side effects that patients that take steroids might have. It's always fascinating to see that these are not just theoretical side effects. And you're all familiar with the excitability, the neuropsychiatric side effects that patients that take steroids report to you on a daily basis. Of course, the changes in carbohydrate and lipid metabolism with overall diabetogenic effect in our patients, the adipose tissue distribution, the bone and calcium metabolism, so both osteoporosis but also the avascular necrosis that might happen to patients and is irreversible. The skin, muscle, and connective tissue, and actually I've just seen in my clinic a young patient that I know who 20 years ago, and when she was still a child, was treated with steroids and has these horrible purple stria on her feet, which will never go away, and so on and so forth. Effect on the endocrine system, of course, the eyes, the gastrointestinal tract, the cardiovascular and hypertension-related side effects, growth and development, extremely important for the pediatrician among us, and not only we see that throughout life, and of course, the exposure to infections and the immune susceptibility that is associated with the use of steroids. So you are all aware of it, or should be aware of it, when you are treating your patients with steroids. So let's see, these side effects actually accumulate. The longer you treat a patient with steroids, this is a known, but still happens, and this is work that was reported by Bill Sanborn to show that if you're treating patients for more than 4 months with steroids, you see that these side effects are accumulating and the proportion of patients experiencing toxicities increasing. And actually, there are serious side effects that are associated with prolonged, what we used to think is low to intermediate dosages of steroids, usually defined as 5 to 10 milligrams of steroids a day. And we learned, some of us learned from our rheumatology colleagues, to say, this is okay, this is low dose. So no, you see that steroid-associated osteoporosis, specifically the ophthalmologic side effects, and the side effects that we are seeing with steroids might be seen also when you're treating your patients with low to intermediate dose steroids. So we want to check again after Valentine's Day success. So we want to check and ask you, in your opinion, if a patient experiences any corticosteroid-related side effects, with whom do they most frequently discuss this with? So with myself, meaning the physician, with the IBD nurse, with their family, or on social media. So please vote. Who do you think patients with IBD discuss steroid side effects with? Be honest. Okay, are we going to see the outcomes? Okay, so I think you were honest, because some of you, and only not the majority of you, think that it is with the physician, Some of you acknowledge the fact that they discuss it with the IBD nurse, with their family, so not with any medical personnel, or on social media. And actually, all of these answers are correct, but you see that the physician is not the major person in this figure. Now, do you fully understand the burden of corticosteroids in patients with IBD? By your own testimony now, the answer is no. And of course, this is supported also by recent information. So we see that clinicians in both IBD specialty clinic and community center may be underappreciating the levels of corticosteroid use. And you see here, this is the overall, this is in the IBD centers, and this is in the community practices. And we all underestimate, whether you ask the healthcare practitioners or the patients in the light blue, you see that across the board, there is underestimation of the use of steroids in your practices. Doesn't matter who you are. And when you're looking in patients with IBD, patients with Crohn's disease actually here, when they're treated in community care centers, this is a survey from Canada and Germany, so representing North America and Europe, they are more likely to receive long-term corticosteroid therapy with lower chance of having steroid-sparing therapies if they're treated in community care centers. And you see the report of corticosteroid monotherapy over 3 months on the left side, and you see here the report of some steroid-sparing agents, in this case the anti-TNFs, but it's also reported for the immunomodulators. So again, in your opinion, where do patients most frequently access corticosteroids? If we said that we're so aware that we shouldn't prescribe them, how do they get them? So, from their own stored supply, from primary care, from pharmacists, or from yourselves? Please vote. How do they get these steroids? Okay, and the answers would be in 3 seconds. Okay, in this case, an educated audience, and you read the reported, no, that's too fast. Okay. Yes. So they get it a lot from their primary care, and in some cases, you prescribe steroids to these patients. So, patients are more likely actually to have inappropriate and avoidable use of steroids from primary care versus secondary care. So you knew it, and it was recently audited and published. So this is from the steroid use audit, and you see that in more than, in about 1,200 patients that were assayed, you see that approximately 15% of them, and Tim already mentioned it in his talk, were using excessive steroids in this cohort. And when you looked at the patients that used excessive steroids, you saw that 50% of them were probably unavoidable, but almost 50% of those patients were receiving inappropriate, excessive use of steroids. So 50% of our patients did not need to get that. And in many of the cases, in the majority of them, the decision to prescribe those steroids was traced to either general practice or secondary care. So you should know what's going on outside of your clinic, but not only outside of your clinic. So I have to share with you a patient of mine. He's now 83 years old. He's actually a very nice gentleman, and I know him for almost over 10 years. He was diagnosed a little before that with Crohn's disease, ileal Crohn's disease, and his physicians did not want to treat him because of his age and several comorbidities with more than 5 ASAs, and he was treated with 5 ASAs. He's very active. He was very happy. He has extraintestinal manifestations, so he has arthralgia, peripheral, and he is coming to our clinic a few years ago with clinical symptoms that were treated with budesonide, starting 9 milligrams a day, and he was doing better. However, after 3 courses of budesonide and still evidence for active disease as seen by endoscopy and fecal calprotectin and additional measurement, corticosteroid therapy was suggested to this patient. And this was because we are aware, as you were aware, that there are rising side effects the more you treat those patients, and it's actually true even more so in the elderly patient population. And you see here specifically how we are addressing the loss of bone in the spine when we're using steroids a lot. And this is coming from Miguel Riguero's group now when they were grading steroids. So of course steroids were put in the bottom of the safety pyramid of our treatments, mainly because of that reason, but not only because of that reason. So this patient actually has disease exacerbation and he refuses further therapy. So we are trying to discuss it with him, and we have a multidisciplinary team, but still he has concerns of side effects. He doesn't want infusion, he doesn't want injections, he doesn't want anything. And he had learned that these steroids have a good effect on him. However, the effect is going down and down. So each time he has an exacerbation, he is using steroids again, and apparently he's treating himself with steroids more than we think of. And when we look at his DEXA estimates, we show that he has significant osteoporosis. And actually, this was clinically apparent as he had a hip fracture, okay? When this was happening, he actually admits that throughout the years, he's using 1 to 2 weeks of budesonide each time he has a mild increase in his bowel movements, even for 4 bowel movements a day. So he's taking 1 to 2 weeks of budesonide, making actually the last few years of this patient exposed to steroids, to budesonide throughout those years with the effects that he had on his bones. So it occurs outside of your clinic, but you should be aware that it might occur in your clinic as well. So we should make small changes that will make difference to patients. Routine follow-up and asking the patient about their corticosteroid use actively is the key. Referral of patients on corticosteroids that are taking them longer term for multidisciplinary teams, but you see that even if you have it, you might fail it. Patient information sheets might be very important for patients on corticosteroids, not only on the new mechanisms of actions that we share with patients. The use of helplines, monitoring of corticosteroid use, and rapid re-access clinics. Like we have a flare clinic where patients can be accessed if they're using steroids, where you can offer steroid-sparing therapy. No, too early. And to summarize, I think that the hidden figures that you may not be aware of what is happening in your clinic and out of your clinic, that prescribing behaviors are obviously not as suggested by the guidelines, that corticosteroid assessment is needed in order to avoid prolonged and repetitive corticosteroid treatment courses. If you don't ask, you don't know. And small changes, of course, may make big improvement for our patients. And actually, I think that what's nice in our discussion today is that we're actually focusing on the patients, what they're really doing, and what we can do to improve their health. And ask yourself when you're leaving this symposium, do you really know why your patients are self-medicating and not telling you, and how we can change that, and with this, perhaps, improve patient care. And with this, I'd like to end, and thank you for your attention.